So thank you so much, everyone, colleagues, friends, for joining us all this evening to discuss a topic that we feel very passionate about: access to innovation, robot-assisted surgery in Canada. This evening, I'm your host, Susie Lau. Just as a brief introduction, I'm a gynecologic oncologist from Montreal, Canada. And I've been working with the Da Vinci surgical platform since about 2007. So this is something really near and dear to my heart. And this evening's purpose is for the seven of us, and mainly actually our panelists, our six panelists, who are varied in terms of their geographic location in Canada, as well as their expertise, to be able to discuss this access to innovation. Can I have the next slide, please? Okay, it's really important for you to know that although we have a few questions and our panelists will be answering a few of those questions, we really want to hear what you want to know. And so if you have a question, I would kindly invite you to click onto the chat button at the bottom of your screen to open up the chat box on the right and type in your question. We have diligent people at Minogue Medical who will be compiling those questions and directing them to us following the principal four questions that we will be discussing. So please feel free at any time to submit your questions. Next slide. So very briefly, robot-assisted surgery globally is really quite impressive. There have been over 8.5 million patients who have had surgery with the robot-assisted platform, and from various subspecialties, from ENT, ear, nose, and throat, thoracic surgery, general surgery, gynecology, as well as urology. Overall, there are about 1.25 million patients that were treated by surgeons of multiple specialties only in the year 2020. And so as you can see in almost all specialties, that curve of surgeries has really been increasing over the years. Next slide. Internationally, in the United States, there are about 3,600 robots. In Europe, about 1,000, and in Asia, about 800, and almost 300 in the rest of the world, which means there are over 6,000 robotic-assisted surgery systems globally. In Canada, however, we have 29 systems. We have 29 hospitals with robotics programs, 3 hospitals with 2 systems. So you can say that we have about 32 robots for all of Canada. And in Canada thus far, there have been 43,000 patients who've been treated with this system since 2003, and over 200 surgeons in Canada trained to do these surgeries. And that spans across 13 cities and 5 provinces. And so, you know, if you look at the numbers, it's impressive that, you know, although our neighbors south are only 10 times our population in Canada, they have about well over 100 times the number of robots that we do in Canada. So you can imagine there might be a little bit of a disparity in terms of everyone having access to this type of surgery in Canada. Next slide. For a lot of the people who are tuning in, you already know this system. For those of you who don't, just permit me 1 minute to introduce you to how these things work. So in the very middle of your screen, you'll see that that's where the robot itself, the patient cart with its robotic arms, are located. And attached to one of these arms is a high-definition 3D camera, which then is placed into the patient and is fed over on the left to the console. And you can see a surgeon sitting in that console where they are actually controlling the arms of the robot. In addition to just controlling the arms of the robot, they also get to see in 3 dimensions. To the right of the screen, you'll see the vision cart, which contains a number of instruments that we use, but in addition is the camera view for some of the other people in the operating room theater. And many theaters have not only this one screen, but several other screens. And what's really incredible, of course, was that surgeon sitting on the console can be a meter away, but can even be overseas to be able to control the robotic arms. And apparently that type of surgery has been done, although not commonplace. Sorry. So without further ado, I would like to introduce you to our very exciting group of panelists who are varied in their expertise. Firstly, we have Melissa Farrell. Melissa is currently the president of St. Joseph's Healthcare Hamilton, which is an academic and research healthcare organization. Melissa is an assistant professor in the Division of Education and Innovation, Department of Medicine, Faculty of Health Sciences at McMaster University. Following Melissa, we have Dr. Wael Hanna. Dr. Hanna is a thoracic surgeon, and in 2013, he completed a fellowship in thoracic surgery at the University of Toronto and joined the Division of Thoracic Surgery at McMaster University. He is Canada's leader in the field of robot-assisted thoracic surgery. He also holds several hospital appointments within the Brant Community Health System, Niagara Health System, Juravinsky Cancer Center, Hamilton Health Sciences, and St. Joseph's Healthcare. We also have Terry Irwin. Terry is the Director of Surgery and Perioperative Services at Trillium Health Partners. Terry is a nurse leader with 20 years of experience in clinical operations, professional practice, quality improvement, and healthcare policy. Can I have the next slide? To complete the next three of our panelists is Dr. Sari Kives. Dr. Kives joined the section of pediatric gynecology in 2003 and is currently on staff at the Hospital for Sick Kids and at St. Michael's Hospital. She is an associate professor at the University of Toronto and is actively involved in the Society of Obstetricians and Gynecologists of Canada. Next, we have Dr. Sunil Patel. Dr. Patel is a fellowship-trained colorectal surgeon at Kingston Health Sciences Center. He has specialized training in minimally invasive surgery, including robotic surgery, laparoscopic surgery, and transanal total mesorectal excision. Dr. Patel specializes in treating rectal cancer, colon cancer, inflammatory bowel disease, and diverticular disease. And to complete our panelists, we have also Dr. Kevin Zoran, who is also a Montrealer and is dual board certified in minimally invasive urology surgery. He's board certified in both US and in Canada and did his oncology fellowship training at the University of Chicago. His focus of clinical and scientific interest is in surgical treatment of benign prostatic hyperplasia and prostatic cancer. Dr. Zoran has completed a very impressive over 2,500 robot-assisted prostatectomy cases. And so with this very esteemed panel, I'd like to go to our first question. The COVID-19 pandemic has resulted in serious challenges for health providers, including significant surgical backlogs. This has led to discussions and implementation of new solutions aimed at providing more efficient care. Minimally invasive surgery has been shown to improve patients' recovery and decrease their length of stay. So with respect to our three panelists, Dr. Patel, Dr. Kives, and Melissa, kindly please describe innovative ways your hospital is working to increase capacity and how access to robotic-assisted surgery helps patients receive timely care. If I can ask maybe Dr. Zoran to start.
Sure, just wanted to make sure I'm off mute. Thank you very much, everyone, for the opportunity. So I guess with COVID-19, I think we're all in the same boat where the initial hit, I think everyone, there wasn't much innovation at the beginning. We worked with Zoom, with telemedicine. I think that was the first innovation. And once we got through that, we had to get our heads around with MIS for the insufflation, right? We all had to understand, are we using different filters, intubation pathways? And then through that point, I think, the other big innovation that came to mind was, I think, with our gynecology team in the multidisciplinary use of different pathways for same-day surgery. I think that's probably been the big push to reduce beds. I think that's our issue, is having the beds, the patients to go after, despite with open or lap or robot. We know robot and lap, minimally invasive, have shorter hospital stay, but the bed issue has been, I think, one of our big issues for the pandemic, and having same-day surgery protocols have been probably, I think, the most innovative thing that I've seen, to which in the last few months we've been actually doing some same-day surgeries for prostatectomies, which follows the lead of our gynecology, which have established the post-operative protocol, pathway, nursing, armamentarium that's been very helpful to ensure quality care, to ensure safe discharge and close monitoring in the event of any issues. So I think that's probably the biggest positive influence of COVID, to allow and adapt further to same-day surgery protocols.
That's terrific. That's really impressive. And I agree with you. We've sort of had that same transition at our center as well. Terry, can I ask you?
Good evening, everyone. Yeah, so just building on what Kevin has said, coming from Peel region, the hotbed of COVID, I almost had to bow out of tonight's panel discussion due to wave 3. I feel like we've pulled a lot of tricks out of our hat to increase capacity here at Trillium Health Partners. We currently have 20 patients in our tent in the parking lot of our Mississauga hospital. We've opened many new beds, used unconventional spaces for short stay surgical patients. And so I think it's really pushed us to think about how we can use innovations like robotic surgery to decrease the length of stay. And I think this really it certainly offers increased access to patients who would benefit the most, but there's certain factors that I think provided some barriers to us using the robot during COVID, and that would be things like specialized training of the staff. Many of our operating room staff were redeployed, and case timing and things like that. And so I think these things need to be weighed with the benefits of the decreased length of stay that robotic surgery provides patients. And so I think in this case, really making the case, and I'll speak to it in the next question that I've been assigned to, for the soft savings that robotic surgery offers for patients, weighed with kind of the hard cost is important.
I think the view of the administration is extremely important, and the collaboration that has undergone this period is amazing. Can I invite also Dr. Hanna to give us his input and his experience?
Thank you, Susie, and welcome everyone. Thanks for having me. I think the administration piece was a nice segue in what I was about to say, because during the COVID pandemic, especially between waves, our administration was extremely supportive of us using the robot, to the point where we got very close to our annual quota, and they said, please keep going, mostly because when surgery was paused during the peaks of the waves, and then we were able to operate again, we found a backlog of big cancer cases that need to be done. Big prostatectomies, big lung cancer resections. And these are normally cases that when done open or minimally invasively will linger in hospital. We had to balance that with the fact that we needed to get patients in and out of the hospital very quickly. And in the case of lung cancer surgery and prostatectomy, the robot was the solution. For lung cancer, where I practice, you can do lung preservation surgery and get the patient out the next day. Our prostatectomies are leaving in 23 hours. And so we were able to maximize the use of our minimally invasive platforms, including the Da Vinci and mostly Da Vinci, to allow for patients coming in and out of the hospital. So it came in very, very handy, and we were able to catch up our cancer cases, particularly because of that.
I would concur with that. Not only were we catching up on cancer cases, but our cancer cases were more challenging with respect to more comorbidities. Were also able to be operated during this time because we were able to offer them the robotics platform and that early discharge. So I agree. It's been a big game changer during this pandemic for us too. In terms of the next question, I apologize, I had listed the wrong people in the very beginning. This question is really directed to Dr. Patel, Dr. Kivas, and Melissa Farrell. In 2020, Hospital News published an article titled "Canada Lags in Adopting Innovation," noting that our healthcare system has challenges incorporating new technology and measuring their benefits for patients. And as a healthcare provider and leader, how do you promote access to innovative technology? And please describe how your hospital implemented a robot-assisted surgery program and evaluated its impact. So if I can invite Dr. Patel.
Right, thanks, Susie. So I think this is a really interesting question. I'm going to kind of start with the second part first. So in terms of implementing a robotic assisted surgery program in Kingston, I think we were very fortunate. This happened about 3 years ago, and it was really a multi-specialty endeavor. And we had a lot of leadership from our urology group who really felt it was very important to offer robotic surgery for their patients to allow them to treat the prostate cancers as well as to maintain their residency program. And we were very fortunate in that our urology colleagues are very collegial and we're very keen to share the platform and technology with us. And so for us, that was very important, is to start as a multi-specialty group. We didn't think that one specialty should own the platform. And that's had a number of benefits for us. We learn from each other in terms of setup, instruments, and kind of thinking a bit outside the box, as well as combined cases. The other important part of our implementation was kind of support from my surgical partners. Dr. McDonald is a colleague of mine. We felt it was very important that two surgeons were implementing and learning on the platform at the same time. We did a shared kind of training pathway together, as well as would work very closely with one of us at the bedside and one of us at the console. We also were very fortunate to have dedicated and very enthusiastic and well-trained nursing staff. Our leadership in our hospital, I think I identified very early on that a kind of smaller core group of nurses was really important so that they could become proficient at the platform and troubleshoot and try to make our lives a bit easier. And I think also the support from the hospital leadership in general. Obviously, this was a new technology for us at the time. They recognized that we were going to go through a learning curve, that all our OR days weren't going to always end early or even on time, and had a significant amount of flexibility with that. So we felt that that was very important. And finally, the support from Minogue was very helpful. They were on site and gave us lots of expertise in that area. Part of implementing and what we thought was very important, as this is a relatively new approach in Kingston, was evaluating the impact. And this was really a point of emphasis. We wanted to show that there was both a clinical benefit as well as a benefit to the hospital system as a whole. And the way we did that is we developed a monthly dashboard that reports things like length of stay, readmission, reoperation, emergency department visits, and has compared that to what our baseline programs are like prior to implementing robotics to try to see, are we better, are we worse, how is the robotic system affecting that. We also created a number of benchmarks, which we strive for, which was things like utilizing minimally invasive techniques, keeping conversion rates low, and then for us, a lot of cancer surgeries done. So we would one of our benchmarks was the quality of the resection, lymph node harvest, margins, and completeness of dissection. So that was really a point of emphasis for us and has been an ongoing real-time endeavor. Maybe I'll just end there. I see I'm running out of time.
You're on mute.
Sorry. Dr. Kivas, can I invite you to give us your input?
So I thank you very much for having me tonight. I think that we all agree that Canada will always lag a little bit behind because of how we are a universally accessible, publicly funded system. And it's very different than the United States when you're trying to bring a robot into a hospital, because we're not a private share. We're not trying to get a market share within our hospital. To promote innovation, we all recognize that we need to be evidence-based. And I think that although we may lag behind, we may be later to the table, we always will show that we want to have the newest innovation. And we recognize that we need to collect this high quality data to show that there's less morbidity and less mortality, particularly in gynecology when we're looking after these morbidly obese patients who need to seek care for endometrial cancer or hyperplasia. Even quality of life data is really important. I think that when we first came to St. Michael's Hospital, we've had the program since 2008. We had a very supportive foundation. They recognized this new innovation. They came behind us. They raised the money for the robot. We got a robot working within our hospital quite quickly. And it was funded very, very well for the first 10 years, where we didn't even have to think about operational costs or anything like that. But that was almost a mistake because no one was thinking about what was going to happen when that 10 years was up. And now at this point, I think the hospital recognizes the innovation of robotics, the importance of what we are doing for, particularly for the urological patients and the gynecological patients. And the hospital is running actually at a deficit to help us continue to run the robotic program because of the operational costs for the robot on a yearly basis. But I think now, as we sit back and we've had this conversation and it's made me think about it, I think it's time for us we're going to have to go back to the drawing board and capture this data that Dr. Patel has identified and that we're identifying to show the importance of what differences we're making for these patients, both in mortality and morbidity and quality of life. Because I think that's the only way we can go back to the government, is we're going to have to show how we've evaluated what's the impact, and now we're going to have to redefine how we're going to continue to keep getting funded, because I do recognize that technology is going to constantly change. We're going to need a new robot, and it's not reasonable to believe that we're going to be able to sustain, a deficit within our hospital to continue running the robot.
I completely agree with what you said, because I mean, when we started our program in 2007, we too had the same kind of challenges. And so from the beginning, we attained and we kept prospectively all of our data. And so we've had a little bit of a hand in publishing some of the data, looking at quality of life, looking at the benefits of robotics compared to different methods of operating. We've done the cost evaluation as well to demonstrate that it is actually cost efficient for both cervix, ovarian, and endometrial cancer to use the robot. But you're absolutely right. I think as a whole, and maybe as a nation amongst our subspecialties, we do need to work together to really show the government more on a national level how impressive this type of technology is and how it's really changed the way we're able to offer care to our patients. Melissa, from an administrative point of view, I think it's really important that we have your input on this question too.
Yeah, so I mean, there's a couple things that I would say to you, and maybe starting at the back end of this question as well, and then going to the first part of it. For St. Joe's, I wasn't here, so this was a long time ago, in fact, close to 15 years. And I know Dr. Hanna will talk about that more, I'm sure, in some of his responses to the questions and to the questions from the audience. But, my understanding of how all this played out here at St. Joe's was that this really was visionary physicians that put this on the table, a foundation with some incredible donors who are willing to back this up, just like you've heard from the other physicians sitting here today. And some, I think, pretty strong leadership at the hospital who said, hey, I think this is going to be the future of surgery, and we need to get in on this, and we need to see how we can help advance this and improve the care delivery. And they took some risks just as what's been described, because there is a cost differential between doing regular and doing robotic. That, yes, I think that there is data that can be captured now to actually show the improved quality, but it, certainly at the time when St. Joe's was starting this, that was not clear. Certainly wasn't clear. We thought there was a value proposition to be made for this, and then of course there was really important partnership with the vendor for St. Joe's as this began too. As the new administrator here, relatively new administrator here over the last 2 years, I have seen and have heard directly and have been involved with the donors and have been involved with the physicians and seeing how incredible the results are when they're using the robots for the services that we're providing here. So I think there's huge value proposition. Plus, of course, our physicians have just done a very comprehensive study really showing that there is actually, there's lots of evidence to support this. And I know that that's been provided to OTAC, and we're really hoping that they'll actually revisit that study that was done a few years ago. Now, what I can tell you too on the front end of this, conversation is the fact that I used to be the Assistant Deputy Minister at the Ministry of Health who had some responsibility for this particular file and who was questioning the value proposition associated with robotic surgery when I was there. And I will tell you that this is a very complicated space for the Ministry of Health, mostly because even that comment that Susie just made, hey, we should be thinking about this at the federal level. Well, that's not how these things get funded. And in fact, we have a very decentralized procurement process where, unfortunately, when you're talking about really innovative technology, the technology companies actually have to go hospital to hospital to hospital to sell it because we don't actually bulk purchase these types of things. In addition to that, there's an expectation within the hospital that these, especially the equipment itself, the operational dollars is something different, but the equipment itself is actually funded through foundations. It's not often government funded. Really, it's only cancer technologies that get funded by the government, generally speaking. So there are these barriers, especially when something is not exactly cost effective, that become barriers to the to the ministry making the decisions around these things.
Absolutely, absolutely. But I'm very glad to hear that from an administrative level, that you are able to appreciate this technology, and I'm sure that you will have a hand in influencing your peers as well. The next question, I'm gonna invite Dr. Kives, Terry, as well as Dr. Patel to answer the following question. Minimally invasive surgery has become standard of care for many, yet for some complex patients with obesity, laparoscopic surgery is challenging or may not be feasible to perform. Robot-assisted surgery has been shown to enable more minimally invasive care across Canada, but there has been mixed acceptance and implementation. What is needed to clarify that this technology benefits patients and contributes to a more effective health system? And what steps can be taken to increase government and hospital support to ensure equal access for patients? Dr. Kives?
I'll just unmute myself. I think it just sort of goes back to what I said initially. We've sort of seen, like, being in practice for the last 15 years at St. Mike's, and we've been using the robot, I guess, since 2008. We're showing that the technology works, the safety, the mortality, the morbidity around the patient, specifically in gynecology and the patients that I'm looking at. But what I've seen, what we've done very uniquely, or not uniquely, but very specifically at St. Mike's, is really kept it to this niche market of patients. We only look after, in our robotic program in St. Mike's, morbidly obese women with BMIs greater than 40. Or with other comorbidities. And we've only operated on those group of individuals over the last 10 to 12 years. Now we have to figure out how are we going to get funded for that? And that's the difficulty. So if the collecting the data is really important, specifically on this niche population. But now I think we need to look, how are we going to go back to the government to get to so that they'll consider funding us? Now, we've always looked at these global funding models, which seem to be failing us because it's super expensive. And I think that one of the things that I've been thinking about is how do we get it more QB funded individually case per case. And I'm not sure if it's possible, but I do think we need to collaborate as a group of individuals, particularly in Ontario. I appreciate it can't be across the country, but particularly in Ontario, we need to look at how we can collaborate and consider getting one voice about irrefutable data saying, listen, if we do not do these cases in this way, these women will not actually even be able to seek care. These patients will be again, disenchanted by the system that will not provide them with any care. So we need to have this one voice and go back to the government, say, this is clear. We do not want to water out our evidence and say it's for everybody. I don't think the robot is for everybody. I think it is really needs to be about these niche populations that we're doing such good things for. And then hopefully, if we have this sort of consortium of acting as a one voice, we can get the government to think about funding it in a case by case, so that we don't. I don't want to have the same conversation in 10 years being challenged on how to continue to support a robotic program within the hospital. I hope that makes sense. Thank you.
Absolutely agree. Terry, please give us some of your insight.
Yeah, so I wasn't sure if Melissa was going to admit that she was at the ministry when OTAC made the recommendation. So I'll admit that I was at Health Quality Ontario at the same time. So so I think it's about advancing the evidence. I think people have touched upon this a little bit. Advancing the evidence to show the benefits that people have described for patients anecdotally, and that is actually described in the evidence currently, but I just think we need more of it. Also, I think it's really important to bring the patient voice into this because the patient experience, I think, is really important and will often speak to the strategy of the government or a particular hospital or organization. And just speaking to things like, less pain, less use of opioid medication, getting out of the hospital quicker, those sorts of things. And then just to build on Dr. Kivas's point about, the niche population and having patients be able to access care who may not be able to, I think advancing equity for patients and access to care. And then finally, I think kind of driving home to hospitals in particular that have academics as part of their strategy, as the importance of offering robotic surgery to trainees to attract the best talent. So those are just some of the thoughts that I had on that question.
That's terrific. Thank you. Dr. Patel?
Thanks, Susie. So I'm a bit humbled to be on this panel with others that have far, far more experience trying to talk to governments about funding healthcare endeavors. But from my standpoint, I think one of the barriers that we've often seen is that in colorectal surgery, there's few surgeons in Canada that are using the robotic platform. But in the States where I did my fellowship, it's very common, especially in academic institutions. And once you get on the platform, it's very obvious to the surgeon what the benefits can be to the patients. Our discharge within 48 hours has gone up dramatically. Our average length of stay has been cut in half with this. And I think it's those types of perspectives, the patient perspective, as was alluded before, that's really important. The other issue, as I see it, is a lot of the data that we get and a lot of the data that's quoted in terms of costs that I see, at least in the research literature, is based from American data or overseas data. Is not always that applicable. So I think one of the major barriers that I see, at least with my colleagues, is the perception that robotic surgeries is dramatically more expensive than laparoscopic or potentially open or other techniques. And I think it's really important for us to show the Canadian data, especially in our field where very few Canadian surgeons are performing robotic colorectal surgery. So I think we need to push, as was alluded to before, with kind of a more evidence-based approach, and one that's specific to Canada and Canadian surgeons and Canadian populations. I suspect equal access to patients will always be very challenging. I think currently there's unequal access to even laparoscopic surgery in my field. And I think this will always be a challenge. I think there's a natural tendency to centralization when new technology and complexity increases, but I still think that will always be a challenge, at least in our field. And then I think the final thing is, exposure to the platform and the outcomes are really important. When you treat these patients, you follow these patients and see their recovery, it's very dramatic. For us at least, we used to have patients that would stay 1 to 2 weeks after some of our surgeries, and now are going home on day 1 or 2, and it's a dramatic change for them. And although we've only been doing this for a couple of years, I have numerous letters from patients describing the benefits, how pleased they were to be to brag to their neighbor that has a big laparotomy scar despite having the same surgery. So I think that needs to be emphasized, the value to the patients themselves. So those are kind of my thoughts on that question.
Yeah. I completely agree with you. I don't think you have to convince surgeons about this. At our center, our colorectal surgeons have yet to really start with the robotics platform. But as a gynecologic oncology surgeon, I have done a couple of cases which involved bowel resection and so forth. And I've brought in our colorectal colleagues, and it's amazing. The first time they sit on the console and see what we see and manipulate the instruments, it's a no-brainer for them. This makes sense, and it's great for patients. And so, having collaborated on with colorectal surgery on a few cases and seeing the results, I think they themselves are very convinced. It's a matter of being able to have the resources to be able to share the robots with everybody who wants to use it, I think is always a challenge. Next question, I'm going to direct to Dr. Hannah, Melissa Farrell, as well as Dr. Zorn. The use of computer-assisted surgery is rising and continues to evolve with new innovations such as augmented vision and training simulation. Having access to the latest medical technologies provides institutions the ability to train and attract top quality surgeons and researchers from around the world. How do you think provincial and hospital healthcare leaders could be made better aware of and incorporate the value of these considerations when evaluating new technology? If I can ask Dr. Hannah first.
Thank you, Susie. We are certainly living in the age of the augmented surgeon. In the next 5 to 10 years, we are not going to be able to do any of the operations that we want to do without either augmented reality or 3D reconstruction or guidance instruments in the operating room. And so we are living in that space now, and it's obvious to all of us. We've heard, when you sit on the robot, it's the greatest thing, but it's not obvious to everybody else. And we as surgeons need to do 3 things to be able to convince other people. The one thing we need to do is to change our culture. Over the last decade, we've always been thinking, how can we do the same operation with the smaller incisions? How can we do a colectomy or a prostatectomy or nephrectomy through smaller incisions using the robot because I can see better? This is not the right way of thinking about things or convincing people that we need robots. In my mind, the question we have to ask is, how can we do operations we cannot do without the robot, that are impossible without the robot? Niche populations have been mentioned, but there are operations that you cannot do without the robot. Minimally invasive prostatectomy in a big bulky prostate, if you want negative margins, you need the robot. If you don't want the patient to bleed out, you need the robot. Lung preservation surgery to preserve the vast majority of the lung and take out a small piece of the tumor, you need the robot. You can't do that by VATS. So when we start turning the narrative to there are things we can do with the robot as augmented surgeons that we cannot do as simple humans with a camera, that becomes an interesting topic for us to discuss. And in order to bring that forward, we need to have skin in the game. So the second thing we need to do is we need to show that we want to be accountable for the data. At St. Joe's, every thoracic surgery patient who goes on the robot is a research patient on a prospective trial. We have imposed this on ourselves. We said, we are not going to use the robot unless it's a study patient, which allows us to elevate our game. And when you have skin in the game, you become passionate and you become proud of your data, and you can publish it and you can show it around. And a lot of the research will obviously contain quality adjusted life year cost data and cost efficiency data to show that it's not really the dollars that you spent, but what you gain in the future for the patient, you know, going back to work in 3 weeks and never having a recurrent cancer again, that actually matters. And the third thing we need to do, which was mentioned earlier, was to bring patient voice to that. We cannot keep saying we need robots because it's an amazing tool for the surgeon. That's not going to work. You need to show that there are some patients who would either not be alive or not be cancer-free, or in my specialty, be wheelchair bound on oxygen forever if they don't get robotic surgery. And when you show that data, those patient-centered outcomes and the quality of life data, you are able to make an impact, because governments and institutions and regulatory authorities listen to patients. And as part of our research, there's always a quality of life component, and there's always prospective patient data that'll be published to show that.
Absolutely, absolutely. Your input is very important from that perspective, and we do have still a ways to work to convince people. Dr. Zorn, kindly give us your input.
So to add to what we just mentioned, actually really eloquent points, and I definitely think that there are certain patients who, especially thoracics or hepatobiliary, where even with standard open lap, you just couldn't do. So I think offering something that exposes that window is a huge area that we need to focus on. But coming back to the elemental question of, you know, innovation and augmented reality, first of all, you know, with the residency training and with training junior staff, I think there's a huge opportunity to bring in additional information. You know, to be a good surgeon, you need to have good information, and to have that at fingertips, you know, integrated into the surgery, I think is going to be huge for reduced complications. You know, the idea of rehearsal. You know, we all hear our favorite singers, or, you know, they don't do a one-take shoot. They've done that multiple times and patched together. And just like Dr. McDougall with her surgical education in urology, the idea of rehearsal, that you can practice and get to, you know, like we've seen people doing 3D models. How about bringing this into real time? And even with computer, having the idea that it will help block out or perhaps avoid injury, there's sort of a little background in the event of any issue. So I think there's huge opportunities for preparation and patient safety, and the whole idea of democratizing the surgeon. So in your first slides, you showed that there are only 32 robots in Canada, to which there's only a certain thousands operated by those 200 surgeons. So the big question is, how can we get this out more? I mean, the first elements of growth, certainly bringing this technology into the robot, kind of like we all have an iPhone, bringing in apps is where I think this is the platform to grow on, to bring that in. So I would think the harmonization of these new computer assisted devices or technologies would be brought in with Intuitive. So that would be my thinking, is what the robotic companies that are there now are thinking of this as well. So certainly that would be at that level. For me, you know, the idea of bringing this into residency training, helping junior staff, and making us all equal surgeons no matter what part of Canada you are, and, you know, breaking off this regionalization of only 5 provinces offering robotic surgery.
Absolutely, I agree. Now, Melissa, not to put you on the spot, but having shared your experience on the provincial level and your experience in the administration level, it's important for us to hear your side in terms of how you think provincial and hospital healthcare leaders could be made better aware of this technology. What can we surgeons do?
Yeah, I mean, I think that's a great, it's such a great question. What I would say to everybody here, oh, you're going to probably all hate me for this kind of answer, but, you know, one thing that I would say to you is that this has come close, and lots of you would know that. There's been, you know, attempts at the government after the OTAC recommendation initially came out to consider, hey, is there some way that we could formalize some kind of robotic, in Ontario, some kind of robotic program in Ontario, and it just didn't fly. It really ultimately came down to the timing of that kind of decision. Also, the cost of the disposables was still really high, and all of that is changing right now too. So there is actually a dynamic with the robot itself, actually, that's improving, I think, the case that can be made with the government. And I would just say there's a really compelling argument to make. There's a lot of evidence now, even better evidence that's actually Ontario-based, that exists now to prove the point, and particularly just how much better the quality can be, you know, for surgeons who are really using this, who have the expertise, and then also why it would be so critical to be using these robots for training purposes too. So I do think that that argument can be made, and I think we're getting closer and closer to, you know, being able to put this back to the, you know, ministry for consideration, especially in the context of COVID and these backlogs. And I know we've already talked about that, but I think that's actually very critical for consideration. In fact, you know, Dr. Hanna will know this, even in, you know, conversations we've been having with donors over the recent history, they've been saying to us, oh, there must be some advantage to using these, you know, using the robots to help us, you know, make up on the backlog. And I think we need to be making that case to the ministry too for consideration, because certainly that is where they're going to be turning their attention after we get through wave 3. So will all of us. We're all going to be concerned. Every administrator everywhere is going to be concerned about how exactly we get through the backlog. And if this can improve length of stay, which it often does, we know that it improves the quality. I think that there's going to be an argument to be made, and the timing is going to be good.
Okay, so it sounds like we have our work cut out for us, surgeons. But I think it's important that we do band together, whether it's amongst different subspecialties or amongst our individual subspecialties within our provinces, but also nationally as a voice. It's important that we be accountable for what we do and be accountable to show what we believe in what this technology can do for our patients. We have a question from the audience. Aside from patients, what happens in securing doctors whose training in surgery has been predominantly on the robot? Meaning many surgeons who are probably trained in the United States, where they have 3,600 robots, I mean, they've received a lot of their training with the robot, and you know, why would they want to come back to Canada? How does the government feel about sort of this, I don't know if you would call it a brain drain, because there are many individuals who are Canadians who do end up going to the United States for training and end up staying. Some of them because the opportunities for them to continue to develop their skill and offer care that they've been used to their patients is not there. Does anybody have any insights on that? Dr. Hanna. I'm going to ask Dr. Hanna, and I'm going to put Dr. Patel on the spot too, because he was also trained in the United States.
Yeah, I think retaining and attracting talent is an investment in our future. I certainly, urology, for example, is a well-established place where if you don't have a robot, you can't really recruit a good urologist who is going to do best practice at your hospital. In my field of thoracic surgery, where robotics is new technology relatively in the last decade, if we think about the future of lung preservation surgery, these are operations that we cannot do but minimally invasively. And what I tell our trainees is that if you want to be a thoracic surgeon in the next 15 or 20 years, if you want to be meaningful in practice, you have to be able to do those operations. And a lot of people want to come to our center to train on the robot and to go back to their institutions and hopefully establish robotic programs. It is coming, but certainly without technology, you cannot attract and retain talent. And that is the biggest investment in the future of our healthcare system. Without the future generation, the minds that are going to think differently outside the box and bring innovation, we are going to stagnate very quickly. And so I think that's a very, very compelling argument that we also need to keep in mind when we talk to funding agencies.
Right.
Sunil.
Yeah, so as someone that came back from the States where I primarily learned on robotic platforms, it is a bit of a challenge. I always intended to come back to Canada. As we all know, the job market in Canada can be bleak at times, which I think is a challenge in of itself. So I suspect there's a number of surgeons that this would be a barrier to returning to Canada after learning on a robotic platform. But I also wonder whether, keen Canadians that have gone down to the States or wherever and have come back will also bring back the robotic experience and could be champions in their hospitals that don't necessarily have a robotic platform at the same time. So, there's a draw to Canada other than just I get to use the robotics platform. There's a lot of other advantages to practicing in Canada over other locations. And so I do think of that as kind of like a hopeful situation in which someone that has had a great experience, great training, and really seen the benefits to robotic surgery can come back and champion the platform in their own hospital or institution.
Terrific, thank you. These questions are great. I'm just going to remind the audience that if you have a question, please click onto their chat button and type your question into the box, and they will get to me. And because we really want to hear what you want to hear. In terms of our next question, again, these are questions from the audience. I'm going to direct this to Terry and Melissa, maybe. Please comment on access to this technology for northern communities, and if there is a potential ability to have doctors from centers of excellence remotely work on these patients.
Did you want to start, Terry?
No, you can start.
Yeah, so I think there's a couple things that I would say. So one challenge that I know is probably obvious to lots of people here, but isn't necessarily, obvious to everybody, is that you'll notice, and I appreciate that Terry's coming from Trillium, but I would consider them to be an academic teaching center too. Often what's going on with robotic surgery is actually happening in academic teaching centers. And it's because of, I think, just the ethos within those academic teaching centers and why they feel strongly that they need the robots for the purposes of training. Like we've kind of talked about a little bit, like there is this kind of push within those centers to put in these robots. It's actually an equity issue at the end of the day. They can also do a better job often on the foundation front and getting the donor base. So the funding in order to support the robots too. And that becomes a really almost impossible feat in the north. Now, there are obviously academic teaching centers in the north who may be able to purchase the robots on their own and actually put them in. And I know that's one part of the answer essentially I'm trying to give you, is that there may be some opportunity within the north. There has been attempts to do this, and someone else might want to comment on this. There has been attempts at using robots, in the north, with the specialists actually being somewhere else in the world. Hey, heck, we're doing this in diagnostic imaging all the time. But it's my understanding that there's big liability issues and insurance issues that have actually stopped us from doing more of that. In fact, we have lots of examples at St. Joe's where that was attempted here. So I don't know if anyone else wants to make a comment about that specifically, but I would say the first hurdle is actually getting the robots in the north if it was not actually a provincial program and something that was, provincially pushed. And then the second thing would be some of the liability issues that currently exist. Maybe they don't anymore, but certainly existed before, that actually was a barrier to us doing that kind of surgery in the past. Terry?
Yeah, and maybe it's, just thinking about it a different way, is maybe it's not about getting the robot in the north, it's developing partnerships, between hospitals where there are robots to have, surgeons trained and whatever. I don't know if that's realistic, but I think partnerships is a good opportunity as well.
That's it. Absolutely. I'm going to go on to the next question. Health technology assessments often overestimate the per procedure cost of robot-assisted technology because they evaluate the technology's use for a single procedure. How can the hospitals and the ministry better assess the value of robot-assisted surgery given its use by multiple surgical specialties for a range of procedures? Now, I know Dr. Zorn, you were a driving force at your hospital having come back from the United States, and you've dealt with your colleagues who share access with the robot. Can you give us some of your insights?
Sure. I wouldn't say I would be the biggest driver. I think our chief, Dr. Saad, and gynecology, they were pushing this way before, so I have to give them credit. And Dr. Denis, people who did the work to get it in. But certainly, I think you're right. When you do a health assessment, there's sort of fixed numbers and boxes of, per procedure cost, but there's some other things that don't, get mixed into the crowd, that, the amortization, that cost, the depreciation value, which in of itself, you're not trying to sell the robot at the end like a house, with it's part of the price of technology and advancing and doing cases that you just wouldn't be able to do, and to put that fixed number is sometimes difficult. The other aspect that we don't always look at the cost are cost of complications or cost of failure and needing secondary therapy. So if you had a positive margin, which in prostate cancer is significant, if you can reduce radiotherapy after, but that doesn't get looked into the equation. Or incontinence, and guess what? You're going to have a secondary surgery for a sphincter. And I can think for other specialties similarly. So that doesn't always get brought into the calculation, nor the external hospital. So the fact the patient can go back to work within 2 weeks, and other costs to society don't always get looked into the picture as well. So I think those are other mathematical pieces that have to be brought into that calculation. It's a hard thing, and I think we all, as surgeons, as people who are from government aspects, that's the big Canadian dilemma, is the cost justification. That's really what it comes down to. I think if we could get robots for free, I think we would all agree that we would all get into it. It comes down, unfortunately, to the math. And when you look at some of these equations, there's omissions, or it's not brought into that calculation of other factors beyond the hospital stay. So I think that's another factor that should be looked into it. And it's, you have to bring it all and put it into the Excel sheet to make value.
Absolutely. Does anybody else want to comment on that question?
Yeah, Susie, I'll comment on that as well. I think probably all of us on the panel have had to talk about costs with the procedures. And one of the issues we often face is the robotic platform is looked at as a new endeavor. And the reality is, if we're not doing it robotically, the surgery we would do, there's another way to do it potentially. Maybe it's laparoscopic or open, and there's a cost to that. So we really try to push what's the incremental cost difference of this procedure, not just what's the cost of the procedure in general. The other thing is kind of taking the cost out of the silos that it exists in, because I don't think it's a fair comparison to compare the disposables on a robotic procedure to what it would cost to do it open, and just leave it at that. I think the fair comparison is the total cost of care to the patient. And I know we've struggled, and I don't think we're unique in saying, well, what's a bed worth? What's an extra day worth to us when you don't just shut the bed down? You don't tell the floor nurse to go home. So how does that impact us? And I think that's been a bit of a challenge. So I think, the cost question is really interesting to me. And I think the other thing that I've experienced, or in general in our specialty, is that I think we underestimate the cost of the other procedures. So laparoscopic technology seems to advance, and there's less accounting for, one-off instruments or new trialed instruments. And where is that cost being accounted for? Whereas the robotic platform, there's a microscope or magnifying glass over top of the program, looking at the cost of this, what instruments you're using, how many instruments to use, what's the life of that instrument or the other one. So I think that's also a very important consideration as far as I'm concerned. And I know it's a challenge in our institutions to do that.
Yeah, I wholly agree. We struggled with that when we were trying to publish our paper as well, because one word you used that was very, I think, eloquent describing the situation is the silos, right? Like you were saying, if our patients get out the same day, that bed doesn't go empty. Someone else will fill that bed, and that's argument that we don't actually explain. Even if our patient doesn't use it, someone else will use that bed. But I would challenge that if we looked at how much it would cost for us to perhaps, treat a patient with colorectal cancer robotically, or how much or how many people we can treat in terms of endometrial cancer, we definitely would be able to see that difference. But, it takes a little bit of a change in mindset, I agree with you, to be able to think along those lines. Yeah. I'm going to take another question from the audience. Ensuring physicians are trained to safely use new technologies and have regular access to practice these skills is important. And please comment on the differences in training and learning curve between open, laparoscopic, and robotic surgery, and how often do you believe surgeons need to have access to technologies to maintain their skills? Okay, do I have a taker for this one?
I'll jump into that one. I mean, I always like to answer the first question is, what is the learning curve? And we have to remember there's another word that we all should be familiar with. It's called the forgetting curve. And it's true. If you look up Ebbinghaus in the 1800s, German psychologist that studied this, that today's meeting, if you guys don't record this and watch this tomorrow and the next day after, within a week, you'll probably only retain about 20, 30% of what was discussed today. And that's just a human fact of we forget. So in the apprenticeship of robotic surgery, that's why we do fellowships. You do something repetitiously every day. Like go to the gym, you'll develop a sense of, you'll maintain that. And just like us, I haven't touched my bike in a little while. I'm sure if I get back, I'll do okay. So we're all kind of smiling, because it's true. I think once you've developed a mastery and a sort of a, you know your steps of the procedure, and you've been through the challenging of, you get to a roadblock, what are my options? You develop that portfolio. So I think once you've developed that, I think there's probably a certain number of maintenance cases per year, but that's going to be very individualistic based on what else you're doing, your age, your other abilities, and your team ability to take on difficult situations. I think that's another aspect. As surgeons, we all go into the operating room and we all have different people in the room sometimes. It's not always the same, necessarily the same construct of anesthesia and nursing teams. So all to say, it's a very challenging question. You'd like to say 5 and 10 and 30, and that's the answer. And it's not. There's a certain amount for learning and getting to a certain proficiency, safety, and then oncological skills. And then after that, you have a certain number to maintain not just your skills, but also the referral pattern that's coming in and your wait list. So I don't think there's a straightforward answer, but I think those are the necessary tools that or items that you have to consider when looking at that question.
Absolutely, I agree. This next question, sort of as a follow-up and in relation to the question you answered, Dr. Zorn, I'm going to direct to Dr. Kives. Although this isn't a new concept, it can often come across as being intimidating. How would you reassure people who don't necessarily know anything about robotic-assisted surgery that this is something people need to be investing in, not only in general, but during a time where much is unknown in the world?
Well, I think that we have the advantage of a lot of technology to demonstrate it. I think that one of the things we have is the ability to demonstrate with the video you showed at the beginning, whether it depends who you're trying to convince, whether it's going to be the surgeons or the patients or the foundation or the government. I think we have to make use of the technology that's available to us. One of the things about robotics that is quite unique is I think that we have a lot of videos to show, to demonstrate the technology. I think the simulation model that robotics offers is really unique. And I think that you can get people on these simulators that are not necessarily surgeons, which actually is kind of nice. I think when you're looking at getting people invested in it that are not a surgeon, it's getting, it's getting the people like with it who are involved in foundation or who are involved in fundraising to actually see how it works. And I think that people get excited by technology when they actually can see it in action. And I've watched that when we did some of the fundraising at St. Michael's Hospital, getting the people into the operating room and on the robot and playing with the robot and moving the little dice around. And it really got everybody super excited that oh my God, we definitely need this technology. So I think that it is intimidating, but at the same time, it's exciting and liberating for other people to see actually how it works. And I do think back to sort of the learning curve with robotics, it's a little bit different robotics as compared to laparoscopy as far as the learning curve. And I think that I find the learning curve a bit, it's a little bit shorter than laparoscopic surgery, or I found coming from laparoscopy. So I think that one of the advantages is the making use of these tools the robot offers with the teaching tools and the simulation, and really emphasizing that.
Yeah, I agree. It's very much akin to what Dr. Hannah was saying also about rethinking the way that we do things, and not just converting what we do from one platform to another, but really rethinking the way that we do surgery. And I figure also that question about the technology being intimidating may be for surgeons that have been practicing for a period of time and taking up this new technology. And, you know, this technology is really so intuitive. And I'm going to speak to my colleague, Dr. Gottlieb. When we started on the robotics platform, he already had an established practice, and not to say that he's old, but was already very experienced. But I think what's impressive is that the platform allowed very rapid progression. And the beauty of it is, it's not that we think that sometimes genius laparoscopic surgeons can't do what we do robotically, but it's that, you know, because the platform is so easy to pick up and so intuitive, that it requires much fewer cases to be able to pick up the skill. And as such, it allows more surgeons to be able to offer that minimally invasive technology to their patients. Because we were at a laparoscopic rate of about 15 to 20%. And during the time that we started, that was really the average across Canada, across North America. And within the first 6 months of doing robotic surgery, we were up to doing about 2/3 of our cases robotically with respect to any endometrial cancer or sarcomas. And by the end of the first year, even, you know, towards the second year, we were up to 98%. And so that's what this technology can offer in terms of the training, the ease of training, and what we can offer our patients. From the audience, I have a question regarding cardiac surgery. And we don't today have a cardiac surgeon on the panel, but which centers are doing cardiac surgery in Canada, and what procedures are the most common? Cabbages, mitral valves? Does anybody have cardiac surgeons at their center? Actually, we do. We have a cardiac surgeon who is using robotics in terms of replacing mitral valves and doing some single vessel cabbages as well. So in the recent years, I have to say that this particular surgeon offering those procedures has been a huge push in our hospital with respect to donors. And it's really changed the way these patients have experienced their disease, rather than having their chest cracked open to having a few little holes, much like thoracic surgery. I mean, it is a real game changer. Dr. Hannah, what do you think?
I would agree. You know, we as thoracic surgeons train in both cardiac and general thoracic, but then we go in one stream. So cardiac surgery, I believe you in Montreal have 2 institutions doing robotic cardiac surgery, and then I believe in Ottawa they do, and it's single vessel cabbages and valves. In the US though, cardiac surgery has taken off, and it is the difference between sternotomy and minimally invasive surgery. But the more important difference is the difference between being on pump and off pump, which is the morbidity of cardiac surgery. A lot of robotic cardiac is done off pump, and you know, being on the bypass circuit is what brings out most of the postoperative complications, and a lot of these operations on the robot can be done off pump because of the stabilization platform that the robot offers for single vessel cabbages. But you know, again, it hasn't really taken off just yet in Canada, and hopefully it will soon.
Thank you. I have received a comment from someone in our audience that recruitment and retention of surgeons has been a challenge in Newfoundland, and they are currently exploring the purchase of a robot. They have gyn-onc, gynecologic oncologist that is a strong advocate for the robot currently, working at Eastern Health, and she was trained in Montreal. So, you know, we have people who are trained, and it must be very frustrating not to be able to have access to a technology that they believe would be beneficial to patients. You know, I'm looking at the time, and it's been a very exciting conversation, and it's been wonderful to have all of the participation and the comments. I guess I would like to now just invite the speakers or the panelists. They would like to offer a final word before we sign off. Okay. Don't everybody speak at once. I think maybe what I'll do is I will share with all of you that it's really exciting. It's been a pleasure to work with people across Canada and amongst different subspecialties, and know that we sort of share this common dream in terms of offering robotic surgery to a broader portion of the population. And, you know, this is a series, hopefully, of webinars to be able to educate people and to be able to sort of start the conversation in how we can improve that access to innovation in robotic surgery. It's going to be really important, please, if you don't mind, those in the audience, your evaluation surveys. That's going to be sent to you, because we want to hear from you. We want to know what you want to know, and if there's any way we can help you to be able to have access to this type of technology or to this type of training. It's really been a pleasure. It's been great. Melissa, Terry, Dr. Patel, Dr. Kives, Dr. Hannah, thank you all so much. And Dr. Zorn, thank you all so much for participating. And I hope to see you again in the future with respect to another webinar like this. And if anyone has any further questions, please include it in your survey. And, you know, we would love to be able to address it with you again at a future webinar. And with that, as the sun is going down, I wish everyone all a good night. Thank you.